Hello everyone, my name is Tanupat Punchalamvichian. My advisor is Dr. Saknan Pongpan Phupakdi. Today I would like to present an article called Dynamic Risk Profiling using Serial Tumor Biomarkers for Personalized Outcome Prediction. Diffuse large B-cell lymphoma is one of the most common subtypes of hematologic cancer, and prognosis of diffuse large B-cell lymphoma depends on many factors, including International Prognostic Index, recent cell of origin, interim PET scan, and circulating tumor DNA or ctDNA during pre-treatment, interim, or post-treatment. The RNA expression that can be classified into many groups, including germinal center B-cell or other subgroups. Germinal center B-cell has the highest survival. And recently, there's a research that used circulating tumor DNA from blood of patients, and they find that ctDNA that is low has higher probability of event-free survival. This research has a nickname called Siri, and it used an idea from win chance probability in sport play that you can see the probability of win during the gameplay. Previous to this research, only single time point of treatment used in predict the prognosis of the disease. But this article uses longitudinal prognostication. That means you can take many time period from pre-treatment, during treatment, or the end of treatment. Okay, start with data. Firstly, they did only diffuse large B-cell lymphoma data, and if their cases data, they will use that. But if they don't have cases, they will extract data from graph like Kaplan-Meier graph. I will first talk about the calibration and discrimination that is used to evaluate how this model works. First, we talk about calibration. Calibration is want to measure how much the model can exactly estimate absolute risk. You will see in the graph here, use like a group of 10 patients and calculate the observed probability and predicted from the model, and we plot on the graph, like the x-axis is predicted probability and the y-axis observed probability, and this one is from moving average. So we have a lot of point here, and they did 528 prediction from 4 time points from 132 patients. And discrimination. What is discrimination? Discrimination is to measure the model that can distinguish or discriminate two conditions by given factors. We use C statistic, or in another name is called area under the curve from the ROC curve. This curve is the area under the curve. By x-axis is 1 minus specificity, and y-axis is sensitivity. So we want the curve to has a high area, so this means it works better in discriminate two conditions. And you will see this picture a lot in this article. From only one factor and combine into C is better. Okay, this model series combine two approaches. The first one is naive Bayes, and the second one is Bayesian Cox proportional hazard model. So I will first talk about naive Bayes. I will start with the first component of the model series. It's called naive Bayes. You will see the left graph. That is the prior for the naive Bayes, and then we update with many factors used in this model, including IPI, ctDNA, or PET scan during or after treatment. And then you can see the calibration and discrimination on the middle and the right graph. Calibration is very good with an overestimate if the observed probability is high, and in discrimination you can see the statistic increase from 60 to 70% to more than 80% if that combines all these factors. This picture shows the prediction of patient A and patient B. That is an examples from this model. You will see that during diagnosis, patient A has very high probability of event-free survival at 24 months, more than 70%, and it increased after she had been investigated with CT, circulating tumor DNA, in early treatment or EMR, and after the treatment called EMR, and IPET is the interim PET scan during the treatment. If it all negative, so the survival is increased to nearly 100%. And patient B is different. Start with the same probability of survival, but after that, if he was investigated with ctDNA and show that it has a high DNA of tumor, so the survival is decreased from like more than 70% to near 0%. Okay, after we run naive Bayes by sampling power and conditional probabilities 10,000 times, we can calculate the 80% confidence interval. You will see in the graph that have the point that is the estimate is expected value, and have a whisker that is the confidence interval. We will talk about another graph in the background later. Next is a Bayesian Cox proportional hazard model. Okay, we continue to Bayesian Cox model. First, we need to compare what's different between Bayesian Cox model and Cox proportional hazard model. Cox proportional hazard model is a model that can calculate the survival function of the survival curve, and if we have multiple covariate, for example, like age, sex, or any factors that influence the survival. But Cox proportional hazard model make worse if it has low sample size, because the interaction and information between the joint of covariate is limited. For example, like if we want to know for only age and sex. Age, if you divide it into 5 groups and sex 2 groups, so we need to have 10 groups that shows the proper survival function and calculate the p-value of each factors. And you will see on the right that if we use this number of sample size, you will see that there is no significant of a p-value from each factors, like IPI, COO, ctDNA, and PET scan. But if we use Bayesian-Cox model, we will give the model the prior probabilities. These prior probabilities are from previous studies. It's like basic background knowledge that we know um, prior to the experiment. For example, like you know that there are 10 articles that show IPI are significant. So we can use these data as a prior. So if we update this, it will include your background knowledge. Next, we calculate likelihood function. Likelihood function um, what is likelihood function? If you would like to know the posterior probability or the update of the prior probability, you need likelihood function. And then the model use a Markov chain Monte Carlo to calculate posterior probability because of the complexity of the likelihood function and the calculation. So and the function is not convex, so they need to use like a stochastic method that can estimate the near truth as much as they can. So they use Markov chain Monte Carlo to calculate the posterior probability. That what is that? Is beta or Cox coefficient. You will see in the lower picture that if the training size low, like less than 50 people, so you will see that the C statistic are much different between this Bayesian Cox and Cox proportional hazard model. Okay, let's see Bayesian Cox model results. On the upper right of the slide shows this calibration graph like before that I have talked already. There's underestimate risk around this point and overestimated around this point, but that only 0.04 and calibration there are two calibration including intercept and slope of the Cox proportional hazard model and it's quite low. And then we see the discrimination from only one single factors to series model include all these factors increase to like more than 80% in every time point from event-free survival 12 months, 18 months, 24 months, 30 months, and 36 months. Okay, next, I will talk about the extensions of the model to chronic lymphocytic leukemia and breast cancer. This one is extensions of series model to include chronic lymphocytic leukemia. You will see that it uses different factors. This one uses pretreatment factors, IPI, like diffuse large B-cell lymphoma, but is for chronic lymphocytic leukemia. This one is interim MRD, is to investigate cells, tumor cells in patient's blood. And this is final in the end of the treatment. Next is the extension to include solid tumor. This is the most common cancer in female, is breast cancer. You will see that breast cancer use only pre-treatment risk factors and pathologic response after surgery. And this one is comparison between Cox proportional hazard with SILI. SILI this use the component of Bayesian Cox proportional hazard, and this one is C statistic, calibration intercept, and calibration slope. You will see that at low sample size, the Cox proportional hazard works worse than SILI. It's all the same in every graph. And the last topic is proof of concept analysis that use SILI as a guide for treatment. First, we see that SILI can be used as a prognostic tool, but this one we try to use SILI as a prediction or biomarker. What therapy that we need to give to patient. This is for CLL. We use only CLL, IPI, and interim MRD to make our model, and then we test it with varied threshold of SILI risk, and we have multiple cutoff and see which cutoff works best to find subgroup of patients that can be treated by FCR or non-FCR. FCR is a combination of chemotherapy, FC and R. And then we find that the threshold is 20%. If you have SILI score higher than 20% of progression by 36 months or 3 years, you will be preferred. Doctors prefer to treat with FCR, and the difference between two Kaplan-Meier curves are different statistically. What is the important assumption they have made when they use naive Bayes for prognostic prediction? A. Conditional probability of factor given event must be dependent. B. Conditional probability of factor given event must be independent. C. Event and factors must be independent. D. Event and factors must be dependent. And E. Probability of event must be normally distributed. The answer is B. Conditional probability of factors given event must be independent.